Hello and welcome to the Cancer Research UK Cambridge Centre podcast, the All About Radiotherapy series. This series is brought to you by the CRUK RadNet Cambridge programme in partnership with our lovely patient and public involvement and engagement group. Hi everyone, today's episode I'm joined by two of our planning and dosimetry team, Hannah and Katie, to talk about their role in the radiotherapy treatment planning and the impact they have on the people coming to the department. Welcome.
Hi there.
Hello.
So first of all, we have Dr. Hannah Chantler, who is Head of Treatment Planning and is running the treatment planning service within the patient pathway. And we have Katie Hutchinson, who is our Chief Dosimetrist. Hannah, I'm going to start with you.
Hello.
Hello. Could you briefly tell us a little bit about your role and what we mean by treatment planning?
Okay, hi there. I'm Hannah Chantler and I'm Head of Treatment Planning and I'm a medical physicist. So as a medical physicist within treatment planning, I have a bit of a mixture of research and clinical work where my main role includes planning patient individual radiation treatment plans, managing the quality assurance of equipment and commissioning and implementing new hardware and software within the department. So my main role is within treatment planning, which is a service that involves physicists and treatment planners working together to create patient-specific treatment plans. So a treatment plan is created on the 3D CT scan of a patient, and we use this scan with some specialist software to optimize the delivery of radiation beams and create plans designed to target the tumor and best as possible avoid the surrounding healthy tissue. Treatment planning also used is multi-modalities. So we use PET and MRI scans that we fuse together with the 3D CT scan. And we use this to be able to delineate where the tumor is. So once the doctor has told us the treatment area that we would like treated, it's the treatment planning team to make that patient-specific plan to target the tumor while avoiding these healthy tissues. And we do this with increasing complexity as our machines have become more accurate and able to deliver radiation more accurately. We're able to make more accurate plans that can specifically focus on this tumor, avoiding healthy tissues. So this comes through complex techniques such as VMAT, which stands for volumetric modulated arc therapy, and IMRT, which is intensity modulated radiotherapy, which means we can essentially shape the radiation around the tumor really well and really accurately. So if there's a tumor very close to an organ that we don't want to treat, we can avoid that organ and still treat the tumor to the dose we would like to treat it to.
And where would we usually see you in the department? Would you see you walking around? Or...
Okay, so you'd probably see Katie more because she works with the specific treatment planners, whereas I'm more on the physics side of treatment planning. So my role is more with implementation and research, whereas Katie's more of a day-to-day, get the service provision going, make sure everything's working, make sure things are on time for a patient to start their treatment. So you'd probably see Katie walking around the department more. The physicists tend to stay in their offices, although we do come down. We get called down because obviously we make these very specific treatment plans on a 3D CT scan of a patient at a specific time, and then sometimes they'll turn up a couple of weeks later and they'll have changed shape for many reasons. And so sometimes the delivery can be different, like the patient will turn up and we'll worry that the delivery will be different because they're maybe of a different shape or something else will have happened. And so physics get called down on set to maybe analyze differences like that. We do quick calculations to see if that's going to affect your treatment plan. We come along if there's any queries at all. We're here to come down and answer the questions or at least help.
Definitely. Lots of big helps. So Katie, we just mentioned how your role differs slightly, but could you tell us a little bit about your role, please?
So I'm Katie Hutchinson, so I'm the chief dosimetrist. So we have a team of treatment planners. They're a range of clinical technologists and radiographers. So quite a few of them have actually been treatment radiographers before. So they've come from set and have joined the team and kind of do what we call the behind the scenes stuff.
Lovely. And just so the listeners are aware, what is dosimetry?
So treatment planning is basically the act, and dosimetrist is actually quite an American term that's come across. And so a treatment planner and a dosimetrist are identical. So some people have dosimetrist on their badge and some people have treatment planner, depending on how the wind blows when they filled in their form.
Fair enough. I've just learned something new. Ooh.
There we go. And so in physics, when we talk about the dosimetry team, we're actually talking about machine QA and calibration of machines and stuff like that. So we have like imaging, dosimetry, treatment planning.
Fine.
Computing, brachy as such.
In that case, so where would treatment planning come into the patient pathway?
Once it's been determined that they require radiotherapy, so their paperwork will come in, they'll be booked for a CT scan. They'll come in, they'll have their CT scan, they'll be set up in the position that they will be for treatment, they'll be scanned, they'll have some marks or small tattoos placed on the patient to enable setup for treatment. They might have immobilization devices such as a shell, or they'll be on a specific piece of equipment that aids setup. They'll have their CT scan, then they'll be contoured by a doctor. They'll approve all those ROIs based on, they'll use their other imaging modalities such as their MRI scan and PET CT to aid with contouring. Then those scans then come through to treatment planning, and the treatment planning team will then produce a plan based on set criteria depending on the area being treated. And we sit down in front of a computer screen, look at the images, work out what dose we can safely get into the tumour whilst trying to minimise the dose to all of the organs at risk that surround that area. And once that plan is completed, it's then checked by an independent person to just make sure that it is to the correct dose, correct patient, correct site. And then once that check's complete, it goes through for an independent dose check. So we're just checking that the planning software has created that plan safely and that it's given the correct dose. And once it's gone through to there, it goes through to the data team. They prep it all ready for treatment. And then once it's through to there, it goes onto the treatment floor.
Brilliant, thank you. And just for the listeners' benefit, when we say contouring, so that just means basically just drawing around different structures in the body, isn't it? It's different organs and maybe the tumor and bits to avoid and things like that. So, and an ROI is like a region of interest.
Yes.
Is that right?
Yeah.
Perfect, thank you. So your role then, even though maybe a bit more behind the scenes, what does that sort of mean for the patient? So it means that, you know, you have an accurate treatment plan made, but what would you see as your main impact for the patient?
I'd say my role is mainly facilitating the planners and making sure that all of the patients come through the pathway as quickly as possible and in the safest manner, so that we don't have kind of backlogs of patients, or we don't have too many coming through at the same time, or not enough people trained up to do a certain technique. So that's my main role.
From a physics point of view as well, in conjunction with the clinicians, we create clinical protocols for each treatment site. And these clinical protocols are based on research and trials, which essentially tell us how much dose a treatment site should be treated with, and also how much the surrounding tissue can tolerate while we're trying to treat that tumor. So we have very specific clinical protocols that allow us to create the plans in the situations that Katie was talking about, when we have strict criteria that we create plans to. So we know that once we've created a plan for a particular treatment site, as long as it's passing the criteria set out in the clinical protocols, then it's a plan that is acceptable for treatment. So after the treatment planning is done, the plan is usually reviewed by the clinician as well to make sure all of these criteria are met. But the good thing about it is that, like Katie was saying, that there's a lot of ex-radiographers there, treatment radiographers. There's a lot of and all the medical physicists that have come into physics are usually because they're physicists that actually want to use their job with an application. So we all have the line of sight where we know that there's a patient at the end of the pathway. And so you get basically physics brains in planning, but with hopefully the line of sight in their mind as well.
Definitely. And it's interesting that you say about the different tolerances for different parts of the body, as that's something I think is quite difficult sometimes for people to understand, that, if there's chatter in the waiting room, one patient will have so many treatments, another patient will have this many treatments, and all we need to worry about this part of the body, and all I need to worry about having my bladder full, for example, for a certain reason. And it's all because of these protocols and research that have said, okay, so this part of the body can tolerate this much, but if we're treating that, we can increase that to this much, and things like that. And it's quite a unique little balance that you have to do in certain times when not everybody's the same. Everybody's a little bit different. Everyone's a little bit different shaped, and things are maybe not always in the areas that you expect them to be in.
Yeah, very much so. And I suppose, and that comes from, with the increase of complexity of planning with all of our new techniques. Obviously, in conjunction with that, we've had to have the increase of complexity of on-treatment imaging, because if we're going to start giving really, really accurate plans, we need to know that they're going to be delivered accurately. And so the cone beam CT on-treatment imaging that we do daily is what's allowed us to become more accurate within planning as well. So it's the whole entire pathway that needs to be in line with each other. You can't become very complex in one part of the patient pathway if you don't have the facility to deliver it in a complex fashion, if you see what I mean. But the thing that always makes me feel slightly happy is that a lot of these criteria have come from research and trials, like you said. And so you're in the right place, if you see what I mean. You know that this hasn't just been plucked out of thin air, and that actually people have researched this.
Definitely. And what's good to know as well is, like you say, is both of you said that, we work quite closely, and we've got ex-radiographers that work within planning, and you guys come down to the treatment unit as well. And we all kind of work very much closely together in different parts of the pathway. So often, sometimes you've been called to right at the beginning when the patient's on the CT scanner, just to say, okay, this is what we can do. This is where we need to be. This is what the patient can do. And this is the position the patient can get in. What can we do to make sure that we can get an accurate plan at the end of it? And that's quite good that we can work in that sort of close team together, which is nice. What I've asked most people on the podcast is, how did you find out about your profession and what brought you to radiotherapy? As I feel like everyone has a very different route into radiotherapy. So it's quite interesting to hear that.
Okay, so I finished a PhD in nuclear structure physics at Liverpool University. And my boyfriend at the time moved to Chicago, who is now my husband, moved to Chicago to do a postdoc. And so I was moving to Chicago to be with him, and I looked up the American Institute of Physics website and looked for a job, and medical physics came up, which was very fortuitous because I was planning on doing nothing for a couple of years in Chicago with my boyfriend and then coming back and doing medical physics anyway. And so I managed to get a postdoc in medical physics in one of the hospitals in Chicago, where I had the clinical job of being a mold rip technician. And then I learned all of the medical physics behind it as well, and did mostly kind of a bit of a research job, but learned a lot of treatment planning as well. And so then I came from Chicago to Cambridge, and I trained in-house essentially. So there are very structured training schemes that you can go on, which are like the scientific training programs, which I didn't do. So you can go very structured. I did not do it. I just came in and trained in-house.
That's super interesting. In Chicago. It was meant to be, Hannah.
Exactly. I was planning on doing nothing. I was planning on volunteering and having a really lovely time volunteering, and then I got a job. It's a bit annoying, really.
Katie, what about you? How did you get into the role?
So before I started at Addenbrooke, I actually studied prosthetic makeup. So I was casting people's faces for making prosthetics and things. And once I came back from university, so I based in Cambridge, but I was actually up in Bradford training. I came back home to Cambridge, and there was a job advertised in the mould room for a mould room assistant. And I went, oh, it's playing with plaster, I can do that. So I applied, came for the interview, and was actually offered a training position. They said, well, actually, we've got a trainee position that we're advertising for. Would you like to interview for that as well? So I went through for the interview, not knowing what I was interviewing for, and was successful. And I did in-house training program and degree all at the same time. So I started in 2005 on the training program, and I went from a band 5 up to my current role. So I've been here for 17 years.
It's interesting that you both started in a mould room as well. So just to explain, a mould room, we use it a little bit these days still, but it's more done in the CT scanner. But we used to make a lot more in-house molds for, well, all parts of the body, but mainly head and neck, wasn't it? And that's where patients would come first and go to a mould room and have all of their like masks or different bits of immobilization made like specific to them, and then they'd come again for like another either CT or an X-ray. Back then as well, we used a simulator. And the last question finally is, where do you both see radiotherapy taking us in the next 5 to 10 years?
Okay, so I think the way that radiotherapy treatment planning needs to go in the next 5 years is into the accuracy of delivery. I think that treatment planning systems are very accurate. And so within treatment planning, we have something that the doctor outlines the tumour, and we call that the GTV, which is the gross tumour volume. We then have a CTV, which is the clinical tumour volume. And around that clinical tumour volume, we put a margin called the planning tumour volume, which essentially takes into account systematic and random errors such as patient moving or more of a bladder filling or things like that when the patient comes to treatment. So the PTV is meant to be there to ensure that the CTV is covered. But obviously, the larger that PTV margin is, the more healthy tissue we're going to be treating, because we're actually having to treat healthy tissue in the PTV margin to ensure that the CTV is being covered. So if we can reduce that margin more and more, then we can deliver doses to tumors and avoid healthy tissue, because quality of life has to be at the forefront of what we're doing as well. So I think that actually the increase in technology on being able to do online adaptive treatment planning, which is where you can look at a patient's anatomy on the day and change the plan accordingly and deliver like a very specific daily treatment plan, is basically the way to go, so that we can reduce these PTV margins as much as we can.
I would say automation is probably the main thing that's going to affect kind of my job role and the role of the dosimetrists. So each patient gets an individual treatment plan, and they're all planned quite similar. So if we can automate some of those processes, and that is coming, so we do have some kind of auto contouring software already. So we are already kind of seeing those changes that actually they can speed up the process and we can get those plans through.
Fabulous. Thank you so much, the both of you.